Good evening, everyone. Welcome to Spine Time. Dr. Mehta, please get started.
Thank you. Welcome, everybody, to Spine Time. As you know, this is our free webinars to discuss spine-related issues. Started back in March of 2020 during the height of COVID. And here we are 3 years later, still going strong. And I am so glad that we have a loyal following that continues to engage with us. For those who haven't had the chance to meet me, my name is Neel Mehta. I'm one of the directors here at the Spine Center on 59th and 2nd. And for those who aren't familiar with the Spine Center, because every week we do get new listeners, it's our multidisciplinary spine organization on 59th and 2nd, which is encompassing spinal surgery, pain management, rehab medicine. And then we also work with folks in neurology, mindfulness, and complementary medicine. And today we're going to introduce a couple of folks that haven't joined us in the past. We are going to talk about research, the evolution of spine treatment, and how research is changing how, one, we treat and diagnose spine-related issues. So we have two folks that are joining us today. First, we have Jessica Berger, who's a research assistant in neurological surgery here at Weill Cornell Medicine, and Abha Kasubhai, who's a research assistant in anesthesiology and pain management, also here at Weill Cornell. So Abha and Jessica, thank you so much for joining. We are really excited to have you. Now, a couple housekeeping points to be made. This is supposed to be casual conversation, so you'll see that it's more of a dialogue. We do have some slides to share, but we'll take questions, and that's where we depend on you, the listeners, to give us the questions that you may have. And I'll do my best to field those as we go. If we don't get to your question, certainly you can email us, or you can come and see us in the Spine Center. If a question may not have a good answer or is very specific to your particular case, we may not be able to give you a great answer just on this program. So with that, Abha, if you can walk us through, maybe for first 30 seconds, talk to us about what drew you into being part of the research department here at Weill Cornell at Pain Management. And then that same question will go to you, Jessica. Tell us a little bit about your background and what you work on and what drives you to do what you do.
Hi, everyone. So I joined the research team here because I thought that clinical research was very exciting, and the pain management division in anesthesiology also works with different medical device companies and is creating new treatments for new patients. And I found that really exciting to be able to be a part of it and help patients get treatments and just help make new discoveries.
And what was your background, education-wise, and where is your future goal?
So I graduated from Berkeley in 2021. I was a psychology major, but I am hoping to go into medical school. So applying to medical school in the upcoming few months.
Fantastic. And Jessica, talk to us, what drew you to working in neurosurgery, and tell us about your background.
Yeah, for sure. I graduated from Michigan last spring in 2022, and I saw the job posting and it looked right up my alley, similar to Abha. I had studied psychology and neuroscience in undergrad, and I think it's a really amazing field. And I loved the combination of the clinical side of it and working with patients, as well as just seeing how much innovation there is to be made in the field. I thought it was really cool. We get to talk to patients one-on-one and do follow-ups. And I also hope to apply to medical school and go in the future. So I wanted some experience with that. And it's also just, they have amazing things going on at the Spine Center. So it's a cool team to be part of.
Great to hear. Thank you for sharing that with us. So what I thought we could do is give sort of a high-level introduction to the various studies that we have going on. We'll start with the pain management side. And the pain management side studies are actively recruiting, which means that you, the listeners, may be interested and may want to come speak to us about that particular study. The neurosurgery side is a little different. Those studies are for people who potentially are having surgery, and how do we improve or learn more about the surgical process. And I know Jessica will take some time to speak to us about that. So the first study is SCOPE with a K, we call that. And it's the one that I'm leading on and working with one of our other research assistants, Kiki Reddy. I know, Abha, you know a little bit about it, but I probably know more. So I'm happy to talk about that one. This is a joint study that we are doing with the NIH, National Institute of Health, and also with Johns Hopkins University. And the idea is that there are a number of treatments out there for knee pain, and they've individually been studied, but they have not been studied in sort of a systematic way or thought of how do they compare against each other or combinations of those. So there are two phases. Basically, there are medication and physical therapy type approach, and then there are some procedure-based approaches. And the idea is to find patients that have had at least 3 months of pain, who have not had a knee replacement before, and potentially enroll into phase 1, which is use of medication, a drug called duloxetine, or physical therapy, or some other pain programs that we have to best manage pain that way, like yoga or online coping skills and so forth. And then phase 2 looks at injections with gel and steroid, or nerve blocks, or potentially even having something where you can burn the nerves that feel pain in the knees without losing control of your knee. And so this is a study that we have a number of patients enrolled into. And again, if you suffer from knee pain and have not had a knee replacement surgery, you are likely a candidate for this. Abha, this is another study you and I work on together. Maybe you can take a moment to talk about SCOPE with a C.
Of course. So this study, we're collaborating with Boston Scientific. So it involves the Vertiflex procedure and the Superion IDS, which is a device that has already been FDA approved and developed by Boston Scientific. So it's implanted in the spinal column, and it's like 45 to an hour procedure. So it's very minimally invasive, and it's used to put in between in the spine to relieve like pain and to relieve the pressure that's put on the nerves because of the compression. And so the primary objective is to compile real world outcomes, as well as evaluate the safety and effectiveness of this implant in routine clinical practice. So it's already been FDA approved, but as per FDA's regulations, we just need to compile more data for patients in a real clinical setting. And so we are currently looking for patients diagnosed with moderate lumbar spinal stenosis that have not undergone any lumbar surgeries in the past.
Yeah, so as you know, working with you on this is a study for a procedure that's already offered, but as part of the partnership with the FDA, Boston Scientific needs to continue to track how patients do with this therapy. And given that we have research experience, they partnered with us to do this. So as Abha mentioned, these are patients that have spinal stenosis, may have had injections like epidural steroid injections, and are getting maybe diminishing results or no longer wish to keep undergoing the same procedure, and could be a candidate for a small implant done under sedation anesthesia with about a 1-day recovery. So again, if you are suffering from spinal stenosis, or if you don't know that you have spinal stenosis, it may mean that you have pain when you walk and stand, but it generally gets better when you sit down or lay down. Use of a walker or a shopping cart relieves a lot of that discomfort in your back and legs. You may be a candidate for this, and so you may wish to come talk to us. So this is more of the study on that. Let's talk about our next study. This is a joint venture with NYU. Abha, walk us through this one.
Of course. So on this study, we're collaborating with NYU to help them recruit more patients for one of their studies that investigates the effect of CBD for pain reduction. So it's a double-blind randomized clinical trial with patients are either randomized to get like a placebo pill or CBD. And so we're currently not conducting any research activities at our site. So we're just directing patients to contact the NYU study team. So if you're interested, you can ask your physician for a flyer and it provides all the information there and who to contact. And the current criteria that they're looking for are patients with that have been diagnosed with spinal radiculopathy that is non-cancer pain and that have been on a stable opioid dose for at least 1 month.
So for those that I'm sure have heard about it, but CBD is in the class of medical marijuana, although is unregulated. So CBD is generally widely available, but there never really has been great research done in how does it work for pain, and especially how does it compare for those that take opioids, and how is the pain relief equivalent that way? So again, candidates for this would be folks that are in pain down their arms or legs, that are on opioids, and may be interested in seeing how CBD works. And let's talk about our registry.
So these are one of our initiatives to kind of aggregate data from a lot of patients. So we've collected data on over 10,000 chronic pain and multidisciplinary spine patients over the past 5 years. So it provides helpful information, both at the individual level and as an overall for patients. So it allows providers to track patient progress and response to treatments, as well as it allows providers to also learn which patient populations respond best to different treatments. And we're also looking at the aggregated data for different research and quality improvement projects.
Right. Yeah, so this is what they call, I guess, big data, and trying to understand how people do over time, and how does that help us guide treatment in the future. Okay, Jessica, you're up. Thank you for joining us again. So the first study in neurosurgery is the stem cell study. What is this about?
Yeah, so with this study, we're looking to see if injecting stem cells from patients' own bone marrow back into their disc space after having a discectomy helps regenerate that tissue and alleviate pain in the future. And we're also hoping to just learn more in general about degenerative disc disease and the causes and treatments. So adults undergoing a microdiscectomy in their lumbar spine with a primary diagnosis of degenerative disc disease would be a candidate for this procedure with Dr. Hartle. So what happens is if you meet the inclusion criteria during the OR, everything goes as normal. It's a minimally invasive procedure. So they actually go through the same incision site that is used for the discectomy itself. And they withdraw some bone marrow from the iliac crest, which is the hip bone. And then while the procedure is going on, there's a centrifuge in the OR and they spin that bone marrow down to get just the stem cell rich portion of it. And then it's about a milliliter or less that they inject back into the disc space. So currently we have about 30 subjects enrolled, 12 have hit the 1 year mark, and we have a bunch more becoming eligible for the 1 year follow-up over the next few months. So we're looking at their patient-reported outcome scores of pain in their back and legs, and also looking at MRI analysis and the signaling in that tissue. So far, the pain scores have significantly decreased over 3-month and 12-month follow-up periods. And it's a safe and feasible procedure to treat lumbar disc degeneration. And we're going to continue MRI analysis and continue enrolling patients in that group, and also analyze patients who have undergone just discectomies without the injection to see how it compares over time.
Great. So those that are potentially undergoing a microdiscectomy may want to talk with Dr. Hartle about enrolling in this study.
Yeah.
All right. Our next study here, if you can help us understand, looks really colorful here.
Yeah, so this one's called the Spinal Cord Associative Plasticity Study, or we just call it Scav as our abbreviation. So we're currently partnered with Columbia University on the study, and it's actually funded by the NIH. So we're learning how the spinal cord signals to the upper extremities, which is the hands and arms. Currently, we're just using this as a diagnostic study. We're just studying that signaling process a bit better. But we're hoping that in the long term, we're able to pair that signaling process with stimulation in the brain at the same time, to help improve motor function and people who've lost that in their hands and arms. So this study has been done in rats and it has been shown to work. It's been successful in rats. So we're hoping to transfer it over to humans. It's a really cool procedure. If you qualify for it, you'd be undergoing posterior cervical spine surgery with Dr. Berger or Dr. Rue at our practice. So in the OR, it's very similar to the surgery you would receive already. Nothing would change as part of your regular surgery or plan of care. But during the surgery, they use what's called intraoperative monitoring, where they put monitors over the spinal cord to monitor its health during the procedure. So the only difference is they augment this process a bit for this study to get a better reading of the signaling between the spinal cord and upper extremities. And they stimulate the brain, hands, and arms and different extremities to see that signaling process. So it's pretty cool. I've got to see it in the OR before. They're looking to see what time intervals, if they stimulate at, and what amount they stimulate gets the best response in the muscles. So far, preliminary results, we have a good map of muscle responses in the organization of the cervical spine, and we're hoping to use that to help guide stimulation and activate the hand and arm muscles selectively and strongly to help people regain that function in the future if they've lost it.
So this is, yeah, I'm sorry, go ahead.
Oh no, go ahead, go ahead. So good.
So I would say this is really exciting work, but it sounds like it's for someone that's had a cervical spine injury and has weakness in their arms. Is that right? Or
not necessarily. People who don't have issues with motor function or any weakness or numbness can still undergo the study, since we're just looking to understand the signaling process better right now.
oh, okay.
So yeah, and there's also a non-operative portion of the study at the Bronx VA, which is pretty cool. So they're just studying the same signaling process, but just non-operatively. You can just go into their clinic, they measure it over the skin with a monitor. So that's really cool too. That I'm not sure if it's the same criteria, but I can definitely look into it if anyone's interested. They have that going on there too. So the goal eventually is to be able to do this all non-operatively to help people regain mobility without surgery.
Great. All right. And sort of like the database that we talked about for pain, I understand there's one here for neurosurgery.
Yeah, so some of you on the call, if you've had a lot of visits at the spine center or surgeries, might be already familiar with these. This is the Quality Outcomes Database and American Spine Registry, QOD, and ASR. Very similar projects. It started as the QOD, and now it's just transitioned to the ASR as things have gotten more online. The goals are to improve quality improvement efforts for patients with spinal deformities, degenerative diseases, and other conditions of primarily the cervical and lumbar spines. So what we do is we use the validated outcome measures over time to assess the extent to which spinal surgery has improved pain and quality of life. So some of those measures we use are pain scales, such as the numeric rating scale, the neck disability index, Ostrostry disability index that measures spine pain, and some other scales for mobility, activity level, emotional health and wellness, things like that. And then the surgeons also will look at some radiographic imaging, operative notes, surgical outcomes. The goal for both these projects is to just get a lot of data on patients who are undergoing surgeries at our practice. Most surgeries qualify for these databases. There are some exceptions, but for the most part, it's just quality assurance. So overall, we're just hoping to look to see if what we're doing is working and help inform better treatment selection in the future, who's a good candidate for what surgery to get the best outcomes.
So this is why we are so thankful for all you listening for filling out these forms that we ask of you, both on your first visit and in subsequent visits. And the more effort and complete those questionnaires are, the better the data it is for us. And I know that sometimes it can be annoying or long or time consuming, but it really does go to a good cause and help your future, folks and neighbors and friends to get better outcomes in their work. Great. And here is something about how people recover after surgery. So help us understand that.
Yeah, so this project, it's abbreviated ERAS. It's for Enhanced Recovery After Spine Surgery, Erasing the Opioid Epidemic. So the ERAS pathway itself, it's a comprehensive perioperative regimen. So that just means it starts before the patient even arrives at the hospital and it ends upon their discharge from surgery. And we're hoping that this pathway helps eliminate the use of long-acting opioids, and it instead focuses more on immediate release opioids and non-opioid pain medications. So any adults undergoing a major or minor spinal surgery at the hospital, NYP or WC, Weill Cornell here is eligible. What we do is we review and analyze demographic, clinical, or perioperative factors associated with success or lack of success in opioid reduction and adverse events or complications from this pathway. And we're just looking to see what medications before and after and what patients may be more at risk than others for opioid use or abuse. So the long-term goals are to reduce the amount of opioids prescribed while still making sure patients are provided with adequate pain control and relief. And we're just hoping to better understand the post-operative pain management path among different types of patients and demographics and types of spine surgery. And just hoping that this helps improve community safety, lower the opioid rate, and hopefully this helps lower overall healthcare expenses for patients in the hospital as well.
Great. Very important tool to understand what's the right amount of medication to use without the risk of the medication causing harm to either the patient or to, unfortunately, the community. Right. And I think this is our last study. Tell us about this.
Yeah, so this is just some examples of miscellaneous projects we have going on at the Spine Center. Specifically, Dr. Hartle, he specializes in minimally invasive spine surgery. So he really likes to look back at a bunch of different types of procedures he does and just making sure all the outcomes are good and what devices are working and which ones aren't working as well. We've had great outcomes for all of them so far. This first example of hijack cages, that's where we're analyzing a series of patients who have gotten ACDF surgery, that's anterior cervical discectomy and fusion. And we're comparing the hijack cage, which is an expandable cage, to patients who have undergone ACDF with just a regular cage that doesn't expand. So just looking at how the spine changes and aligns differently after the insertion of that cage. So that's been a cool project where it's currently in the process of analyzing pain scores and imaging. The next project, we call it Slalom. That's like kind of our abbreviation for it. The actual procedure is a unilateral laminectomy, bilateral decompression. That's a wordy one. That's a 10-step paper we're in the process of getting put out to instruct others how to perform that procedure as well, because we found a lot of success with it. But it's basically a way of making a certain type of procedure more minimally invasive. So we call it Slalom because it kind of looks like a ski slope where they make incisions like alternating levels on the spine when they go in to do the laminectomies and decompressions. So it's a cool procedure, and we saw a lot of reduction in pain scores and postoperative complications with it. And the last one is TLIF. That's a transforaminal lumbar interbody fusion procedure. We're looking at rise and sable cages. So again, just two different types of cages. One is the rise cage is more conventional, and the sable is a hyperlordotic cage. And we're just following patients and their outcomes after that, looking at radiographic imaging and pain scores to see which patients do better with which cages, and again, help inform treatment selection in the future. So just a little example of all this stuff we have going on, but it's been really cool to be involved in.
Great. So kind of finished going through our slides of the active studies here. And part of our goal of sharing this today was to talk about both research opportunities, but why we feel we are doing really cutting edge work. Maybe you could talk a little bit about some of the experiences that patients have shared with you about being part of research and why it's been so gratifying to be part of it on your end.
I can start by sharing my experiences. So one of our other studies that I did not mention, as we're not currently enrolling any patients at our site anymore, is called SOLACE. So this is also collaborating with Boston Scientific. So it's the implantation of a spinal cord simulator, so an SES, for people with low back pain that have not had any prior lumbar surgery. We actually had a few follow-ups this morning, and it was so amazing to see how patients really have improved a lot of their pain. So just like 3-4 months ago, they had rated their pain a 9 out of 10, and today it was a 0 or a 1 out of 10. And so it's so exciting for them to be able to use this new technology to help reduce their pain. And also a lot of them would not be able to get the spinal cord stimulator if it wasn't for their study, or they would have to pay a lot of.
I was asking about that. So they're potentially getting treatment not available to the general public because of insurance access or so.
Exactly. So for this study, Boston Scientific is covering all the fees for the patient. So the patient doesn't really have to pay too much except for maybe a copay here and there.
Fantastic. And how about you, Jessica? Any stories or experiences that you'd like to share about being involved in the research?
Yeah, I would say very similar to Abha. It's just amazing to talk to patients when we get to do the follow-ups with them and see how much their pain's improved over time. Especially with the QOD study, we get to talk to patients since we have more time on our hands than the physician. Sometimes we had talk to them for 15 to 20 minutes and see how they're doing. And I've had so many people say to me their whole life was changed after surgery. They were in so much pain before, and now they can go back to skiing and traveling and seeing kids and things like that, which is really rewarding to hear that the things we're doing and projects we're doing are helping. So it's really nice to see that. For the stem cell study, kind of similar to what Abha was saying, our study covers the cost of the follow-up MRIs. So it's really nice that patients can see their progress and not have to worry about insurance covering it and getting that special type of MRI after, which has been really cool. And Scav Study also, just to be part of something that I know is going to help people regain mobility in the future, is really exciting as well.
Great. There is one question in the chat. I'll say that it's been quiet today, but one question about troubles between C5 and C7 and causing, debilitating hand pain. Certainly sorry to hear that, that you're experiencing that. Just off the top of my head, potentially the NYU CBD study could be something to talk about with the pain management group here. If you haven't already seen one of the pain management doctors, certainly give our office a call, and that can be done through this number. And even if it's not a study that we're not actively enrolling, there may be past studies that we can draw knowledge from there. I always like to take a moment to explain why I think research is so important, but how do we do the research that we're doing? How do we get money for that? Abha, you've mentioned a couple studies that are fully funded by the company that produces that particular product, and without it, we wouldn't have the money to study it at all. And then Jessica, you talked about the National Institute of Health, funding one of the studies. Have you seen other ways that studies have been supported? What have you experienced?
For us, a lot of Dr. Hartle's projects are grant-based. So either organizations or patients can donate to his research fund if they're interested in his research and passionate about the outcomes. I'm not sure the exact logistics of it, but if anyone's interested, I can put my email in the chat and ask him. And then also sometimes certain projects will fund the study. So for example, the quality outcomes database, since it's a national database, typically they'll give us some funding for how many patients we can get enrolled and how many follow-ups, if we hit the follow-up quotas. So some studies are like that as well.
Great. Yeah, and sometimes the department, if they have some funding the neurosurgery department or the pain management department will throw some money that they may have from their savings to get a project up and running. And certainly it's difficult to have all the money covered for an entire project. So many times we do get extra funding from that. With that said, I know we're coming up on 5:30, and again, we're open to any questions. If there are no further questions, then we encourage you to look for past episodes of Spine Time on our YouTube site, which the link is listed here. If you have any clinical questions that we weren't able to answer today, certainly come and see us and you can make an appointment. And in 2 weeks, we will be back again here on Spine Time. And I apologize that I don't know the topic offhand. I think it is related to recovering from spine surgery and the things to do and not to do after spine surgery. So with that, I'd like to thank my co-hosts here, Abha and Jessica. Very exciting to have you on this and be part of your transition from college to medical school. And thank you to the Spine Time team for organizing this, and for all of our audience, have a good night.
Thanks so much for having me. It was great to be here.